Everyone, first, we'd like to thank Dr. Ariane Veronica for inviting us to participate in this ICOS meeting in its Latin American chapter. Our special thanks to Stephen Caselli for the kind support and invitation. Today, we'll present a clinical case, a young patient who came to the emergency room of the Mãe de Deus Hospital and complained of dyspnea. Dyspnea triggered our care protocol we performed in the advanced cardiovascular screening room in the emergency department. Before we start, I would like to introduce our integrated oncology service. We are here in Porto Alegre, which is located in the extreme south of Brazil. The Mãe de Deus Hospital is a general private hospital with 400 beds, and our oncology department invested in the oncology center. Oncology department is led by the colleagues Alan Azambuja and Jairo Liuboy. Thanks for the leadership and support. For us, it's very important. Dr. Marcelo Capra is the leader of the hemato-oncology field and is a great partner in the new thrombosis in hemostasis department that will be launching in the October 13th. This new department will be a great boost for oncology, providing the great integration with the various medical specialties in our hospital. Dr. Marcelo Miglioranza is our link with the image department, as we'll see during the presentation. A good team needs an exceptional coach. The business direction is carried out by Mr. Leonardo Morelli, and all of our projects have the signature of Carmela Nicolini. Finally, I asked my colleague and longtime partner, Eduardo Schlabendorff, to take charge of the meeting to present the case report and introduce the colleagues who were crucial for the outcomes of this case. Please, Eduardo.
Thank you, Dr. Euler. Good evening, everyone. My name is Eduardo Schlabendorff, and I am a cardiologist and a co-coordinate together with Dr. Euler Manenti, the cardio-oncology service at Mãe de Deus Hospital. It's a great pleasure for me and our team to participate in this ICOS webinar again. Today, I will present a case that I conduct as a cardiologist, and that made me understand how important it is to teams to work together, especially talking about cardio-oncology. Let's start the case presentation. It's a 23-year-old male university student who had not had any disease until that moment. He was really healthy, had not been using any medications, drugs, tobacco until that time. He just had a treatment for an orchitis with ciprofloxacin 2 months before. He was evaluated in October 10th, 2019 in our emergency room of our hospital with complaints of pain in the epigastrium with irradiation to the right hypochondrium that had started a week before. The pain worsened after respiratory movements, and it is persisted for a week, increasing in the intensity significantly the day before the admission to the emergency room, and was associated with dyspnea on minimal efforts. On physical examination, the patient was in regular general condition, had a tachycardia, tachypnea, without compromising oxygen saturation. He had high blood pressure levels, and there were no other changes in cardiac or pulmonary auscultation. He had mild pain on palpation of the epigastrium and the right hypochondrium. without any signs of peritonism. There were no changes in lower limbs perfusion or signs of edema. Let's start by showing the EKG upon admission that shows sinus tachycardia and sinus arrhythmia, left atrial overload, and an evident S1 K3 T3 pattern that demonstrate overload of right chambers. Now we have the first chest X-ray that seemed normal to our evaluation. The first lab tests reveal a mild anemia, leukocytosis with associated lymphopenia, and normal platelet counts. The dimers level was extremely high, and troponin and BNP were normal. He also had a normal kidney function, as well as a normal urine test. Let's hear from Dr. Marcelo Miglioranza, who will comment on the findings of the cardiovascular images that were done for further evaluation. Dr. Marcelo Haertel Miglioranza is one of the best cardiographists of our hospital, and he always helping us with his great expertise. So I would invite Dr. Marcelo, please.
Thank you. Good evening. So I was called to perform a bedside echocardiographic examination during this patient admission to ICU. Here you can see 4-chamber view, focus on right chambers. And if you pay attention to the right ventricle contractility, we can look at the McConnell sign. It's a hypercontractility of the apex of the right ventricle related with acute core pulmonary syndrome. We can also look at a huge mass inside the right atrium going through the tricuspid valve and to the right ventricle during this diastole. This mass was reaching the right atrium through the inferior vena cava. Next, please. Next, please, Eduardo.
I just passed.
Okay, thank you. So we performed a 3-dimensional reconstruction of right atrium and this mass. You can look that the mass have irregular borders, heterogenic echogenicity, and right now we could not discard the possibility to be a thrombus or different origin mass. It's impossible to determine the etiology of this mass. Next. We have talked with the ICU physician about the size of this mass and the probability to be a source of embolus. And they asked for angiotomography to evaluate all the pulmonary arteries and also the systemic vein to look the source of this mass. Here we have some transversal views from the thorax. We can see a huge mass again inside the right atrium. The cut below this on below left, we can see the presence of this mass inside the inferior vena cava and with a continuous to the left renal vein. And also we can see in a very low cut the presence of enlarged testicles. Next, please. We have reconstruction, coronal reconstruction. We can see all this mass coming from the inferior vena cava through the right atrium. And also we can look here the continuity of this mass through the left renal vein. And also we have some other transversal cuts to see again the presence of this mass inside the inferior vena cava. It was not possible to see the presence below the left renal vein. Next. Due to the enlargement of left testicle, this patient was submitted a testicular ultrasound. The right testicle was normal, and the left testicle we found enlarged dimensions and the presence of a solid, rounded, and heterogeneous imaging, predominantly hypoechogenic with multiple cystis area. The size of this mass was 3.8 to 2.3 centimeters. Epididymis was with normal appearance. Next.
So I will continue the first day of our Panade mission. And the initial management of this young patient was to promptly initiate the anticoagulation therapy with low molecular weight heparin, enoxaparin, because his signs and symptoms of possible pulmonary embolism, which was reinforced by laboratory observations, EKG, and CT scan, even though it was difficult to access the pulmonary arterial circulation due to its low contrast of CT scan. The patient was transferred to an ICU bed for clinical and hemodynamic monitoring, because we are concerned the potential migration of the thrombus into the pulmonary arteries, thus requiring urgent treatment. Considering the alterations in the image exams, we request an oncological evaluation that we start the same day, and the oncologist, Dr. Vinicius Lorandi, will soon comment on it. And it's important to say that at the time, we did not end up indicating thrombolytic therapy because of relative clinical improvement, and also due to the lack of ventricle right ventricle dysfunction or hypotension, as well the positive response in the initial treatment. However, in the following day, the patient presented a significant clinical worsening with some signs and symptoms that could be related to low cardiac output, despite his high blood pressure. And this clinical status was even more compromised because the patient had a supraventricular tachycardia, although it relatively improved after the intravenous metoprolol. This new scenario called for a new pulmonary and abdominal CT angiography, because we are still not sure whether thrombolysis or percutaneous surgical thrombectomy would be necessary. And it was then that we decided to create a multidisciplinary team with oncologists, cardiologists, cardiovascular surgeon, and an interventional radiologist to discuss the better treatment for this patient. So I would like to invite Dr. Eduardo Saadi to comment on the new CT angiography and his surgical evaluation at the time. Dr. Eduardo Saadi is the head of cardiovascular surgery department of our hospital, and he makes some difficult situations easy because his great experience and unique ability in this surgical field. So please, Dr. Eduardo Saadi, go ahead.
Thank you very much, Eduardo. Good evening, everyone. I'm sorry, but I couldn't turn on my webcam, so you are going just to listen my voice. In this CT that was previously described by Marcelo, there was a moderate pleural effusion on the right side, as you can see here, and there was extensive filling defect in the venous circulation of the abdomen that extended from the renal vein to the right atrium, running in the suprarenal portion of the inferior vena cava, with an heterogeneous enhancement to the use of construct media, compatible with intravascular thrombus. There are signs of occlusion or subocclusion of the suprahepatic portion of the inferior vena cava. The most important sign here on the CT is that it seems that there were no invasion of the vena cava wall, and it looks like a thrombus inside the vessel.
Please comment your evaluation right now, Dr. Eduardo Saadi.
So as we had on the CT the testicle tumor and this thrombus, usually we see this tumor thrombus more related to renal cancer, but we have operated a lot of renal tumors inside the vena cava and the right atrium, but not so far, no one from testicle. So our hypothesis was that probably this was a tumor thrombus, that the origin was in the testicle, and that through the gonadal vein, it went into the left renal vein, and then into the IVC, and then into the right atrium. So this was our main hypothesis.
So now let's call Dr. Vinicius Lorandi to comment on his evaluation and the patient's follow-up. Dr. Vinicius Lorandi is very good oncologist of our hospital. He is very dedicated in providing the best care for every patient, and in this case, he was very important for the success of this case. So please, Dr. Vinicius.
Thank you, Eduardo. I'd like to thank both you and Dr. Euler to invite me to comment on this case. So, good evening, everyone. I'm a medical oncologist from Brazil, as already was presented. So I was called in to evaluate this young male patient admitted in the ICU who presented with a probable advanced testicular cancer. The patient presented with involvement of the left kidney and a massive extension of what it looked like to be a tumor thrombi, all the way from the left venous vein to the right atrium, showing a very important clinical worsening in the last few hours. So that's the case that I was presented at that time. Also, I'd like to mention that this was, of course, in a Friday afternoon. And but remember, at this point, there was no biopsy or histology to confirm or guide anything, only a presumption of a left testicular cancer. This patient, of course, needed urgent treatment, and I ordered some tests, HCG and alpha fetoprotein, which both came out positive. And therefore, with this both tests positive, it allowed me to treat him as a non-seminoma testicular cancer. So due to the high chance of response with cytotoxic chemotherapy in testicular tumors, I chose to start BEP, which is a protocol of chemotherapy composed by bleomycin, etoposide, and cisplatin, in an attempt to seek a high and rapid response rate to decrease the intravenous thrombi component. Next, please. So when you review this particular patient, you know so young and so sick patient in need of urgent chemotherapy in the ICU, a few concerns came to my mind. There was a high risk of a rapid response, especially in the retroperitoneal disease, which could lead to a massive bleeding, especially when on anticoagulants. Tumor lysis syndrome is also a possibility due to this extension of the disease, for which allopurinol was started. We also know that cisplatin is a known drug that causes nephropathy. Patient needs to maintain a high urine output as shown there. And this protocol is a very bad protocol of chemotherapy on nausea. I started him on prophylactic olanzapine, which is an antipsychotic that have been used over a few years now for controlling nausea. And also another concern of one exposed to bleomycin is the exposure to a high flow of oxygen, which may lead to pulmonary fibrosis. Next, please. So only 24 hours later, the patient had received his first cycle of chemotherapy. He already presented a great improvement in hemodynamics, and the tachycardia was controlled. There was also a transient worsening of the renal function, and patient also developed a neutropenia and frequent bacteremia, for which he required broad-spectrum antibiotics and Neulasta, which is a white blood cell stimulating factor. As you can see there, his HCG came down from 253 to 49 only after one cycle of chemotherapy, and his alpha-fetoprotein came down to over 13,000 to around 6,600. This is a great improvement of tumor markers, but we'd like to see a little more. We'd like to see a logarithmic decay on the tumor markers. But I find this was a very good response for at least this high component of disease. Next, please. The patient then developed thrombocytopenia, which complicated with hematuria and needed a temporary suspension of enoxaparin. After a relative improvement in platelets and bleeding, fondaparinol anticoagulation was initiated by the cardiology team. Next, please. So just a summary of his going in the hospital. On the October 31st, he actually went on the orchiectomy, which normally is taken before chemotherapy, but in this case, of course, we could not take him to surgery before. On November 1st, only one day after his surgery, he got his second cycle of BEP. And on November 6th, he was able to be discharged from the hospital with a very good improvement in his general condition. He was kept on anticoagulation at home. So he was discharged with edoxaban 60 milligrams per day, bisoprolol 1.25 milligrams per day, and also enalapril 10 milligrams both in day. Next, please. Just to show the decay of tumor markers, HCG came from 250 to undetectable after 3 cycles of chemotherapy, and the alpha-fetoprotein came down from over 13,000, as I showed you before, to 169. Then on the 27th of November, he was exposed to the 3rd cycle of BEP. Next, please. On December 6th, he then had a catheter implantation for chemotherapy. On December 16th, he received his 4th and last cycle of BEP. And on December 29th, he had to be hospitalized for pancytopenia. So we were very sad to maintain this young boy in the hospital for January 1st, but we had to. He presented with a sinus infection and was treated with amoxicillin and clavulanic. Next, please. And finally, here we can see all tumor markers were negative after the 4th cycle of BEP. You can see the alpha fetoprotein came down to over 13,000 to 4, which is a normal result, and HCG remained undetectable. So I guess now I'm gonna let Dr. Eduardo Saadi comment a little more on the surgery.
I think we can go next slide, Eduardo. So we decided to do the operation that we usually do for left cancer with IVC and the right atrium involvement, which includes the first step, complete removal of the tumor in the abdomen and dissection of the left renal and inferior vena cava, and then to open the chest and doing cardiopulmonary bypass while we excise completely the tumor thrombus from above and from behind. So as you can see here, there's a short time of cardiopulmonary bypass, around half an hour, and less than 20 minutes of aortic cross clamping. I think we can go to the next slide, Eduardo. So it's very important to do a very careful dissection in the abdomen to avoid bleeding, because we are going to heparinize this patient and put on cardiopulmonary bypass. So you can see this is not really a minimally invasive surgery. It's a complete midline laparotomy and a midline sternotomy. And so here you can see on the left the thrombus tumor completely removed since the left renal vein that was reconstructed. And here the upper part is the part that was inside the right atrium that was removed simultaneously from above, from the right atrium, and from below, from the inferior vena cava, while the patient was on cardiopulmonary bypass and with stable hemodynamics and controlled bleeding, that we can recover all the bleeding. Here we can see it's a very interesting image on the top of the left tumor. It's a small horn that, if you observe the echo that Marcelo did, we can observe that there's this sort of image. So as you can see, fortunately, there was no dense adhesion with the inferior vena cava wall, so we can remove completely the tumor from the abdomen up to the right atrium. So I think we did, we already mentioned the description of surgery. So the tumor mass next to the renal hilum was dissected as the renal artery, and then we did a sternotomy simultaneously to extract the whole tumor and do a completely oncological surgery together with the urologist and the oncology surgeons of the hospital. This was a team operation. Next. Thank you.
Now we ask it to Dr. Euler Manenti to talk about the postoperative evaluation.
In test this great trauma in the post-operative evaluation in the ICU, the patient rapidly wake up after anesthesia, 20 hours of low dose of norepinephrine, but only to maintain blood pressure. He had a good tissue perfusion, no neurological complication, no increased bleeding in the stay. 22 hours stay in the ICU bed. It's a very, very nice post-operative moment for this guy. How Eduardo Schlabendorff said that the Dr. Saadi team make the thing easy for us. The hospital discharge, the discharge prescription of the chlortalidone, telmisartan, amlodipine, only medication direct to the hypertension. The patient was a very, very nice recovery in the follow the in this moment in the hospital. Nice evolution. It's all.
Please, Dr. Vinicius Lorandi, tell us how about the follow-up and make some review about the testicular cancer.
Okay. So after the surgery just shown to you, the pathology report from the thrombi came as a mature teratoma, as well as the lymph nodes, all of them came as a mature teratoma. I should add here that this is a possible part of a non-seminoma testicular cancer that does not respond to chemotherapy. So just to summarize, this case was a advanced non-seminoma testicular cancer, clinical stage 3C, also classified as a poor risk disease due to the high level of alpha-fetoprotein. Next, please. And just to speed up here the follow-up of the patient, all of his recent reviews are all clear of any disease. He just was seen by me in an outpatient care and came with new CTs, all showing no evidence of disease whatsoever. And the patient is doing great. Next, please. Here's a small review on testicular cancer. It's actually 2% of all malignant cancers in male, 10% of all malignant diseases affecting the male genitourinary urinary system. The germ cell tumors are actually divided into seminomas and non-seminomas. Treatment include resection of the testis, epididymis, and spermatic high ligation, and also retroperitoneal lymph node dissection. Chemotherapy or radiotherapy may be used, but remember, this is a highly chemosensitive tumor. High cure rates, even when we have advanced disease, can be reached. We consider nowadays that around 90% of patients can be cured only using chemotherapy in first-line treatment. Next, please. So testicular cancer, complicated with an inferior vena cava tumor thrombus, has been rarely reported. We only found 4 cases of inferior vena cava invasion in over 650 testicular cancer patients assessed by tomographies. Pulmonary embolization is the most severe complication of inferior vena cava thrombi, and it can lead to sudden death. And approximately 9% of the testicular cancer patients died of pulmonary embolization in autopsy cases. So I guess that with this we came to a conclusion. We all would like to thank for your attention, and we'd like to open this for discussions in the panel. Thank you very much.
So hi, this is Joe Carver from Philadelphia. That's an amazing case, and the care that you gave is like beyond belief. So I congratulate you guys. It's just, there's not much I can add except that because platinum drugs tend to stay in the vascular system for decades, that he continues to have an ongoing risk of vascular events, and that we're pretty aggressive in lipid management, and you clearly have been aggressive in blood pressure management. So it's also a curious observation that these guys tend to get a metabolic syndrome and gain a lot of weight. So being involved with cardio oncology early really is a major benefit in preventing the late sequelae of BEP chemotherapy. Great job, guys.
Stephen, only a little commentary. This is one demonstration that we will have a team very integrate. You can rapidly to begin the best approach for the patient. And the heart team in the cardio oncology team, it make this difference in this case. It's a very, very nice outcomes because the team work together again.
Hi, good evening, everyone.
Good evening, Veronica.
Hi. May I ask a question now? First of all, congratulations for the excellent presentation and challenge to manage this case. In fact, it's a wonderful case. I have 3 basic questions, if you could please answer. The first one is just for an explanation for everyone that is listening here. The reason for the high blood pressure in this case is we are close to a young man with no comorbidity, no risk factors, nothing before. So he opened his clinic presentation with the pain, okay, it's okay, but a high blood pressure. It's interesting to try to explain to everyone that's listening to this. My second question is there any previous symptoms of pain in the testicular area? Nothing was mentioned by the guy. It's very unusual, especially for me that usually work with adolescents and with some young boys. So the main manifestation, clinical manifestations, the high volume of the area or some kind of pain in the area. So that's my question. And the last question is that why he's keeping the high blood pressure even after surgery, even after chemotherapy, even after his improvement, clinical improvement. So I'm very curious about it. So we are dealing with 2 major complications of cardiotoxicity, high blood pressure and the risk of thrombosis. So thank you very much, and I appreciate your answers. Thank you.
Thank you for your questions. Actually, no, when I will just answer one of this. When I was performing the echocardiography exam, I thought that when we saw some mass like that, we need to think about hypernephroma or seminoma. And then I asked him about his testes. He report that about 1 month ago, he started feeling enlargement of his left testis. He performed a visit with a specialist, and simply they did not care about. They say that it could be normal, and the patient did not follow any other medical visit or evaluation.
One comment that I'd like to to introduce. It's about the hypertension during the ICU state, because there is a very disconnection between the image, the ventricular, right ventricular function, and biomarkers. Fortunately, this patient don't gain hypotension in them, hypertension. That then make us to refer the thrombolytic therapy. That is very disaster for this patient. And after the moment this start, this maintain a very control this pressure, because the post operation time to maintain and diminish the risk of bleeding of this patient, because the area involved in the trauma in the venular system, and I think it is very important to not maintain this patient in hypertension. But the explain of the why this patient stay on hypertension, I think the most easily explanation is about the renal involvement, the hemodynamics, renal hemodynamics. I think it's the most easily manner to interpret this kind of manifestation.
And Veronica, the patient was treated 2 months before the admission for an orchitis. So I think he was symptomatic about this tumor before, but the diagnostic is not well done at that moment. So I think he was symptomatic, but in the time after admission, he didn't complain any pain, just the enlarge of the left testicle.
Just to add to what my colleagues just said, since I had many consultations with this patient, he eventually mentioned that he was ordered a new ultrasound of the testes and did not go look for it. So I guess the patient was either scared or didn't care for that very much. But he never came back to the urologist who ordered the test. So.
Thank you, and God bless you that treated this guy. Excellent. Does anybody else would like to make a question or comment?
Maybe Miglioranza can to explain the differential diagnosis in the tumor and thrombus in the image. Is possible or not possible, Miglioranza?
Actually, this is a very tough differential diagnosis. Most of the mass inside the heart could be a metastatic cancer. Usually, we think about thrombus when the patient have all a clinical profile, a clinical picture that is very compatible with thrombus. This imaging was an isoechoic with some heterogeneity, irregular borders, so could be both mass or thrombus. We usually look for presence of flow with a color Doppler. This mass didn't have a flow inside, so then we could think more about thrombus. The same we can say about angiotomography. We did not realize the contrast going inside the mass, so it does not have vessels, with low flow inside the mass, we usually think about thrombus or a benign cancer tumor. So it's very difficult. We need to assess the clinical picture of the patient to complete diagnosis. But when we see a mass like this coming from the inferior vena cava, we need to think in seminoma or hypernephroma.
I just like to emphasize the importance of the multidisciplinary approach in this patient. The group of cardio oncology is very active, and I think that the timing and the patient in each treatment was the secret of the success of the treatment of this patient. Because when we see this big mass inside the right atrium, our tendency is try to do the operation as soon as possible. And in this case, I think we had a multidisciplinary approach and staged chemotherapy, and we wait for the right time to operate the patient. And the operation was just one step of the whole treatment. And I really strongly believe that this collaborative approach was the secret of the success in this advanced disease.
And the hospital needs to have the necessary complexity and professional with expertise to guide the best treatment in this case. And we face some difficult decisions that arose during the treatment. And some moments we feared that the patient wouldn't survive. It's a really difficult case, but working together in a multidisciplinary approach was the key for the best result in this case for me.
Ahmed, did you have a question?
Yes, I had a quick question. In terms of long-term thromboembolic risk, is there any risk in these patients, or because initially there was a concern that this was thrombus and PE? I saw that he was not discharged on anticoagulation.
I think Vinicius Lorandi can tell about the situation of the oncologic improvement. In this moment, we came from home without endoxaban. They use endoxaban in the moment, but in this moment, he is very well, living a normal life without anticoagulation. Can
Exactly.
to help us, Vinicius,
we just used anticoagulants during his time of chemotherapy and during the time that he was still with the tumor thrombi. Of course, even though we thought it was a tumor thrombi, we cannot rule out that there are any vascular or platelet thrombi as well, because of the extension of the tumoral thrombi. So we kept him on anticoagulants just only the time of the treatment with chemotherapy. Also, cisplatin is a known thrombogenic factor. So I also, even though if he didn't need a formal anticoagulant, I was gonna probably keep him on it during the time that he was getting the treatment.
Great, thanks for the answer.
Could you please tell me if you are going to use any ambulatory monitoring of blood pressure to try to withdraw the drugs in a short or medium time for the clinical cardiology team?
Schlabendorff, would you like to ask this question?
Yeah, we're trying to do that, but the patient don't take the medicines very well, so it's difficult now to remove the medication. Yes, but we plan to seek the monitoring blood pressure and try to remove this antihypertensive treatment.
Dr. Vinicius, is it usual or rare the involvement of the contralateral testicle of
Very
the patient?
rare. This is very rare. Normally, when you see a patient with testicular cancer, you see only one testicle with the tumor, and normally when you have retroperitoneal component with lymph node involvement, you see them on the same side. So that's exactly what we saw here in this patient with a left testicle and then left retroperitoneal lymph node and left kidney as well.
Do you see that it's necessary, or if it's usual to use another kind of imaging, like PET-CT, to detect another part of metastasis or something else?
No, actually, the only role for PET-CT in testicular cancer could be on seminomas. Whenever you have a patient that went on surgery and remained with a mass in the retroperitoneal space, and you're not sure if that mass is either a residual disease or necrosis that didn't have time to get smaller. So you may use PET-CT, but PET-CT in non-seminomas is not a very good test for residual disease. We can follow these patients with CTs, or either I prefer abdominal MRIs because because he's very young and he's going to be followed for a long period of time. So a test that doesn't add toxicity and radiation is actually a better choice.
Thank you very much. Is there any other question in the audience? Thank you, Steve. Steve, the word's yours. Thank you very much, guys. Wonderful team, an example for our country. Thank you very much.
Please, at the end, I'd like to express my gratitude to stay with the ICOS again, and we are growing. The cardio-oncology team is growing, and in next month you launch the thrombosis and hemostasis department that it's with together the cardio-oncology. I think we have a large team, more people work together to make the difference in cases like this. I'd like again to thank ICOS the opportunity and to care and maintain safe, because the COVID-19 yet is in this moment in Brazil is very, very hard. Please, thanks a lot, Veronica, for your kind support to our team in the Porto Alegre Mãe de Deus Hospital.
Also like to thank for all the support by Stephen Caselli and the kindness of our leader in Brazilian cardio-oncology, Dr. Veronica Santos, who is very dedicated to spreading knowledge and by gathering people in her special way to taking care of all of us. And thank you, Veronica, for your support, and thank you all.
Thank you all for this just remarkable presentation and fantastic illustration of the value of cardio-oncology. So we look forward to many years of work together, and I think the things that you all are learning together, you need to write, you need to publish, you need to continue to do work like this, because it is a model not only for Brazil but for the whole world and how cardio-oncology should be working. So thank you for your tremendous work.
Thanks, Steve.
Thank you, Steve.
Thank you.
And
Good night.
It's the first
Thank you very much.
anniversary.
Thank you,
1 year
Steve. Good night.
work together.
yes, terrific. Thank you all, and everybody be safe and have a good night. Thank you.
Thank you. Bye-bye. Good night for all.
Bye.
Good night.
Thank you.
Thank you, Steve. Thank you, everybody. Bye-bye.
You.
Thank you, Veronica.
Thank you.